Thank you for coming to class today. I will tell you that you're our third group, and I think by attending this class, we've had a 100% pass rate. So attend to the class, ask questions. We're going to go over everything ad nauseum. I am going to do at least one head to toe on Roselle here for you. So then you'll see the flow we're after, and then we can do as many as you want. Roselle and I can do it as many times as you want. I want you fully comfortable and fully feeling great going into it, okay? No surprises. We'll just go over everything. With the PowerPoint, I am going to really, there's a lot of information in the PowerPoint, but I will tell you for the purpose of the exam what I want. There's a lot of extra information that isn't pertinent to this head to toe, but it is very pertinent for your practice, okay? And we'll go over, I'll also go over as part of this little class, I'm going to tell you sort of, because I did mostly everybody's assessment, you know, I was gone for 3 days, so I missed some people there, but I'll go over the most common omissions that I saw. So just so you know what most nurses are missing, all right? So we'll get started. I will start by saying that I've been an ICU nurse for 37 years. I do a lot of the training in the ICU. I put on a lot of classes. I will tell you that in the ICU, and Roselle was one of my preceptees, there is nothing I put more focus on than the head-to-toe assessment. It is the single most important thing, the single most important thing you're going to do in your career as a nurse. We can show you how to hang every kind of presser, show you how to operate a ventilator. I won't say I don't care about that, but I kind of don't care about it. I'd way prefer you to have a brilliant assessment because you're at the bedside. You're at the bedside for your whole shift, and a doctor is going to come in for maybe 5 minutes. You're the one who's going to pick up on everything. You're the one who's going to pick up on a decompensating patient. I also want to sort of move your thought processes away from focused assessment a little bit more too, because really when I know we see a patient maybe with hypoxemia, maybe with sepsis, whatever it is, and yes, we can concentrate on that, but when our patients decompensate, we need to do a head-to-toe assessment because we need to try and figure out what's going on, right? Certainly when I'm on the rapid response team, when I go on a rapid, I do a head-to-toe assessment. I do not do a focused assessment. All right? So with that, let's start. Okay. So for the purpose of this whole little class, we're going to do about 40 minutes on the head-to-toe. Then Roselle and I will demonstrate a correct head-to-toe. You can ask questions at any time of the presentation. Then we'll take about 20 minutes really, and more if you want to, practice on each other. And then the test out probably takes about 7 minutes, all right? And then let's go into why we need to do a really good head-to-toe. So we need accurate and timely assessment. That is crucial for our patients, that they receive the most prompt attention and proper treatment. It provides us with essential baseline data. It helps us to gain insight into the current health status. We also derive information on their previous health status, right? We do an admission assessment. We find out how they're doing at home. Is this reason that they're coming into the hospital? Is this a recurrent reason? We look at their health needs and their goals, and then ultimately what we can do to expedite them getting out of the hospital and how we can support them going home. And then it helps us trend data and looks for changes. A really good example of that would be you go into your patient's room, they don't look great, you do a sepsis screen, oh, positive sepsis, rapid response comes up, they validate it, we check a lactate and it's 3. And we do interventions, and then 3 hours later, is the patient responding to our interventions? Is the lactate going down as we hope it should be, or is it staying the same or going up? So we identify something, we do an intervention, and then how's the patient responding to it? Timely intervention, so important, especially with our stroke patients. Time is brain. We need to identify that this patient, something new is happening. We call code stroke. We break the patient's CT, they get TNK, and hopefully resolution or improvement of their symptoms, right? Nurse assessment is fundamental to patient outcome. I can't even stress that enough. How you interact with your patient, how you assess your patient will result in them getting better if you're picking up on stuff, because we know patients will decompensate if we're not picking up on it, right? And then nursing assessment is always a bit of a thorny subject for nurses. Only 11 of 40 nurses in graduating classes score 70% or higher in their assessment, and then 76% of cases resulting in missed or delayed diagnosis was due to inadequate assessment. That's a high number, 70%. So that's why we're here. That's why we're going to work on our assessments. Okay, so the hallmark for everything with our patient is ABCs, right? We always think of ABCs. Except for now in ACLS, we do CAB. Are you all ACLS? Yeah. So now when we go to a code, it's all about circulation, because studies have shown through the American Heart Association that, starting good compression straight away really improves patients' outcome. And we minimize the amount of time we're not compressing. The only time we don't compress, pulse check and defibrillation, when we clear the bed. But if you ever do a code with the code team here in-house, you will see that we never stop compressions. Compressions, out the gate. You'll only stop for defibrillation and pulse check. So that's really important. But for the sake of our patient who's not coding, we're going to look at airway. And we look at a lot of things with airway. Are they able to speak to us? Someone with impairment in ventilation won't really be able to speak. Are they sleepy? Are they chain stroking? Are they apneic? Are they hyperventilating? Like, how is that airway? Do they have an open airway? Are they wheezing so much that barely any air is getting in? Are they in stridor? So we look a lot at airway. Breathing, is it effortless? Does both sides of the chest rise up and fall down equally? Patients with a pneumothorax, you may only see one side ventilating. Patients with injury to their diaphragm, you may see one side of the diaphragm going up or down. Is the patient getting fatigued? We see that a lot in the ICU. They come down on CPAP from the floor for, respiratory distress, and then they come down to the ICU, but they're pooping out, and then we would intubate them, right? Are they using accessory muscles of respiration? That's a big one. Patients cannot go on very long using accessory muscles of respiration. If you see their intercostal muscles retract, if you see them belly breathing, if you see their shoulders shrugging to help take that breath, not a good sign, right? That patient is fast going towards intubation. Circulation, look at my little pointer stuck there. Circulation was a big thing nurses were missing in their head-to-toe assessment during skills. They weren't checking skin color. They weren't checking their pulses. This is a very, very important assessment that we need to do, because the skin is our largest organ in our body, right? Our skin, when it's perfusing beautifully, is warm, it's pink, you'll have a brisk cap refill, they'll have full sensation, the color is normal, the temperature is warm, right? They have good sensation. They'll have brisk cap refills. If that patient is not circulating, if they're bleeding out, say if you were on the 5th floor and the patient was in the ICU with a grade 4 liver lac, they're not out of the woods when they come up to you, right? What if they're still bleeding? They're going to be shunting. If they're still bleeding, they're going to shunt blood to their vital organs. The peripheries are going to be cool and pale. Okay, what if you send your patient to IR for, I don't know, for something, and they come back and you check a pulse and now they have no pulses in their feet and it's mottled, cap refill is greater than 3, you know, we really need to be checking skin signs. It's imperative. Safety, we need to make sure we're checking the right patient, so always check your armband. Correct patient's name, correct patient identifier, their birth date, their age. So when you come in as part of your assessment, the very first thing you're going to do, you're going to knock on the door, you're going to come in, identify yourself, and you're going to check the patient's armband, okay? Make sure you have emergency equipment in the room too. So if you have a patient up on the floor, they're not oxygenating great, they have a ton of secretions, make sure you have adequate suction with a Yankauer, an ambu bag in the room with a mask. Make sure you have everything you need. If your patient's on telemetry, make sure the red dots, you have 5 on the chest, and that you can see a nice waveform on your Philips monitor. Bed should be always in the low position. Tracer. Tracer means you have IVs hanging. When you come in on duty in the morning, you're going to check that that is the correct IV hanging. You're going to follow the tubing all the way down to the insertion site at the IV. Is that IV working? Is it leaking? Can you get a blood return? You know, these are all the things we should be checking with Tracer. If you give an antibiotic, check to make sure your allergies, the patient isn't allergic to penicillin, right? Like, we need to double check stuff like that. If you're hanging 2 things at once, make sure they're compatible, right? Foley catheters should be below the level of the bladder, hanging on the bed frame, not on the side rail. Make sure that you empty it when it's 2/3 full. Make sure you're checking the output, the color. Is there a smell? Check the odor. Check if you have any sediment. You should have clear yellow urine, right, with a good amount, 0.5 mL per kilo every hour. And if you don't have that, investigate. Okay, assessment. When do we do it? We always do it on admission, full head to toe, not focused, full head to toe, at the start of your shift. Now, we're doing this push out in the ICU, that we do a portion of our shift change in the patient's room. We go in, then you welcome your new nurse that's coming on, and you introduce them to the patient and the family members. You look at the IVs together, make sure what's running is supposed to be what's running. Do tracer. And then if the patient's in, especially for neuro, you're going to do a neuro exam with the oncoming nurse. This is very pertinent for the NIH. Have you all done the NIH? Have you taken care of the patient? No? So the NIH, and we're going to be going over it. I think all the floors are going to get educated on it, but this is the exam that we do for stroke, okay? The reason I'm bringing that up is any 2-point change at the NIH, we have to call a code stroke, or on the floors, rapid response. And it's easy. There is some subjectivity in there. If I lift up my arm and it's drifting a little bit, I might say that's a 4 out of 5. You might say it's a 3 out of 5. If you put 3 out of 5, that's a 1 point increase, you know. And then if we say the patient, if you might say the patient's dysarthric, I might say, it sounds normal to me. That's another point. So now there's a 2 point difference and the patient has to go for a CT, right? All right. Always do a full head to toe if the patient's condition changes. I go up on rapid responses a lot. Patients come in for a variety of admitting diagnoses, and we can hyper-focus on that admission diagnosis, but there could be other stuff going on that's either making the patient's condition worse, or it could be something completely different. And the only way we're going to capture that is by doing a full head to toe. Reassess based on your unit protocol. Anytime your patient goes to the OR, to IR, doesn't matter if you had that patient this morning or for the last 3 days, you need to do a full reassessment head to toe. And then bedside handoff. Okay, these are some of the tools we use for head to toe, but we sometimes have a lot more tools, right? So regarding head to toe, never lay hands on your patient with a stethoscope or your hands, A, until you ask permission to do so, B, you never do an assessment through the patient's gown. Always take the patient's gown down. And then you're going to inspect the chest, inspect the abdomen, inspect the head. Inspect first, look, listen, and then feel. So when we think of the abdomen, for example, I'm going to look at it first. I'm going to look at the contour. I'm going to look for distension. I'm going to look for bruising. I'm going to look for hernias, maybe a wound vac, whatever, colostomy. Look first. Then you're going to listen, and then you're going to palpate. So at the beginning of the exam, say my patient said, oh, I'm here because I have cirrhosis of the liver and I have a really painful liver. I know that my liver, most of it is in my right upper quadrant, with some of it going over to the left. If I already know before I even get there that this area is super tender, I'm not going to mash on it, right? I'm going to be very, very tender with that patient. Okay. So you're going to introduce yourself to the patient. You're going to introduce yourself. You're going to say how long you're going to be with them. You're going to walk them through the head to toe once you validate that this is your correct patient, right? You're going to look at their armband, name, their date of birth, their age, tell the patient what you're about to do, and work from head to toe. So nurses in the previous classes have said, I do my head to toe when I'm at the head and the arms, I do everything up here and then I move down. You can do your head to toe in whatever order you want, no judgment from me. However, I will tell you, if you don't follow the order, you're way more apt to miss something. For example, very common one, missing the pulses. People listen to the heart sounds on the chest. Then they go straight to lung, abdomen, completely forget about the pulses. So when you're on circulation, you're going to listen to the heart sounds, then check all your pulses, head to toe. And while you're down at the hands, remember always two fingers to check for a pulse. Then go immediately up and check my cap refill. You're going to check for color, temperature. What else do I check? Turgor. What else? Temperature. Right. Color, temperature, sensation, turgor, cap refill. They're the ones that I need. So do that while you're under circulation, and then you're just not going to forget it. All right? Okay. And then please, please, please use translation services. We've had a few instances in the ICU where we've had, say, Cantonese speaking people. The nurse is using family to interpret. But family sometimes will only tell the patients what they think they want or need to hear and not what you want them to hear. So it's just way better to use translation services. Okay.
Also, like from what I've been told, medical interpretation is like really hard to do, even if it's like
absolutely
that you're fluent in.
100%. And that's exactly right. You know, medical terminology can be hard for people, you know, or we could say something they've no idea, maybe they're too shy to say it. So I think, honestly, that's a very good point. It's, you know, and honestly, if it goes to a court of law, you know, these are all certified translators. I don't know how well your case would stand up if the patient. So I had no idea someone was going to drill into my brain because no one told me, you know. All right. General survey. So the general survey, this is what we see when we walk into the room. Is my patient sitting up in bed, putting her lipstick on and combing her hair and spritzing with perfume? I mean, most of our patients aren't doing that, let's be clear. Most of them are crawling out over the side rails, maybe poop on their hands, maybe, you know, gown could be on or off. That's mostly what we see. General appearance. Their affect. This is how they're, I suppose, how they're interacting with us. So patients can have a very flat affect. We generally will see that in traumatic brain injury or in frontal lobe insult, where they talk just monotone, bit of a delay in speech, generally yes, no. There's no intonation in their voice. We call that a flat affect. Generally speaking, these patients are, you know, they're not interested in their surroundings. They don't initiate anything. It's very frontal lobe. The verbal responses that they give us tell us a lot. Are they awake, alert, and orientated by 4? And we'll get into this in a sec. But also, do they quickly respond to you? Is their speech instant? If I ask Jasmine a question, is she going to immediately respond? That's normal. Some of our patients have a large delay in speech. They may be orientated and they may respond appropriately, but there's a big delay. They may also be coming back with us. I might ask Jasmine her name. I had a kid in the ICU 2 days ago. I asked him his name, and he said January. Then I asked him where he is. He said May. He had Wernicke's aphasia, so he had like bleeding on the left side of his brain at the parieto-temporal border, and that's where my Wernicke's lobe or speech center is, and that's expressive aphasia. So he could understand me, and sometimes they can't with aphasias in that area, but he couldn't respond appropriately. And then the next day I came in and he could do it all. It's fascinating. So sometimes the verbal response to speech is clear, but it's gobbledygook, okay? And then speech quality. When we look at speech quality, generally speaking, with our traumatic brain injuries, injuries in the anterior circulation of the brain, Broca's area in the frontal lobe can be affected, and the patient knows what they want to say. They're trying to say the appropriate thing, but their speech is either very slurred, or maybe slightly slurred, but it's different from what it should be for them, okay? I slur my words. I'm Irish. I have a different accent. I'm sure somebody would say that I had a stroke. Maybe I have. But right now I'm not having a stroke. But somebody could say, I have some dysarthria, right? Always ask your patient, is their speech correct for them? Do you notice a difference in your speech? If they have a Broca's aphasia, they should know their speech is slurred. They should know that they're having some difficulty getting words out. Wernicke's and the parieto-temporal lobe, they won't. Okay. All right. Level of consciousness. Patients can be wide awake and chatting, but they can also be confused, right? So we do want to go through the 4 orientation questions with them. Awake and interactive. As I said, they may be speech clear, seem awake, but they can be confused. Lethargic is, though, they're sleepy, they're a little drowsy, but if I go in and gently shake them, or if I go in and go, hey, wake up, Jasmine, you should wake up. And then you should be able to stay up. You're drowsy, you know, you're not right. Then getting into like deeper states, stuporous patients don't like it when you wake up. They don't like that, right? They try and push you, they can try and push you away. Obtunded patients cannot maintain arousal. You go in, you go, good morning, they do nothing. You go a little bit deeper, wake up, they don't. Then you're, wake up, and you give them a sternal rub, you pinch their sternocleidomastoid. They'll open their eyes then, but if you take the noxious stimulus away, they fall straight back to sleep. And comatose patients, they're just not interacting with their environment. Okay, so some potential causes for alteration in level of consciousness. These are common ones. Stroke. A new stroke, our patient's probably going to be a bit sleepier. Seizures. Have you all seen seizure patients? Seizure patients have this like burst of activity in their brain. It's a hypermetabolic state, and then the brain calms down when the seizure stops, but it's resetting. During that reset period, it's your postictal state. That can go on for a few minutes to several hours. So if your patient's sleepy post-seizures, it's their postictal state. We also generally give Ativan. We can give Ativan and Versed. We can give Ativan, Versed, Keppra, and maybe Dilantin. All these drugs are going to make my patient sleepy. Infection, we've seen it. Our patients become altered. They're becoming septic, right? They get sleepier. They just don't look well. Allergies, please always check your allergies before you administer anything, because we don't want to put them into anaphylactic shock, right, nurses? A lot of drugs will make our patients sleepy. Top ones being opioids. We give a guy down in ED 100 of fentanyl before we do something yucky. He's going to probably fall asleep unless he's doing a lot of drugs on the outside. Then we'll probably just give him more until he's asleep enough so we can do whatever we need to do. But drugs definitely alter our level of consciousness. And with that being said, if you go in to do your head to toe assessment in the morning, please, please, please don't slam your patients with 2 of morphine, 4 of morphine, 0.5 of Dilaudid before you do your exam. Just tell your patient, I just need you to be clear for this exam. I need to see your head to toe, and then I'll give you pain meds. And then hypoxemia is a huge one. You have a patient on CPAP all night. They've been pulling that frickin' CPAP map off all the night, driving you insane. The CPAP is going off. Now the patient seems sleepy in the morning. You come in, call a rapid response. We get an ABG, and the PCO2 is 60, right? That patient will end up getting intubated, because these patients definitely will be altered with a high PCO2. Hypoglycemia, that's a huge one. If you call a stroke alert, first thing you're going to do is get a blood sugar, right? Patients become extremely altered with low blood sugars. All right, they can seem confused, and maybe you can't wake them up. So just be very aware of that. So, for the sake of this test out, I'm only going to ask you to know this. Person, place, time, situation. Person, what's your name? Place, where are you right now? If they say hospital, I'm fine. They don't need to give me Eden and the address, right? A lot of our traumas come in, they have loss of consciousness at the scene. You're happy enough that they know they're in the hospital, right? Yeah. But you can orientate them, say, yes, you were in a road traffic accident, you had loss of consciousness at the scene, They brought you into the ED, you're at Eden in Castro Valley.
I usually do tell people.
Yeah,
that.
good
Like,
girl.
I'll be like, did they tell you where they took you?
Yeah.
And they're like, no. I'm like, okay, you're at Eden.
Okay, good girl, good girl. For the sake of time, we only ever want the month and the year. I barely even know myself it's June right now because we just changed. I keep wanting to say May, but I know we're in June. I certainly barely know the day of the week. Is it Thursday? I don't know. We've been doing head to toe all week. I think it's Thursday.
Especially when you work night shift.
Yeah, I know. It's very hard. So month and year. And for the NIH exam, you only need the month and the year. Okay, so let's keep it simple. And then situation, ladies. Situation, look at me circling it. So many nurses forget to say situation. Why are you here? What brought you to the hospital? Person, place, time, situation. Please don't forget to ask them that. If they can tell you, I tripped over the cat, I hit my head, and suddenly I'm here, good enough for me, because they've lost consciousness and they kind of have an idea of the chain of events. Know your patient's baseline mentation, and has there been a change? We live in the middle of a bunch of nursing homes here. We get a lot of patients with dementia. But how's their dementia in the nursing home? Are they generally quite compliant? Are they generally not crawling out over the side rails? Like, we want to know what's delirium versus dementia. We love to give our patients delirium in our ICU. We love to make 90-year-old ladies absolutely crazy with all the drugs we give. But we kind of, I always run, or if I have time, I'll call the home to see how is she normally. You want to know if there's an escalation in the symptomology, right? And then I don't need this for the sake of the test out, but we do look at cognition, we look at emotions, we look at verbal responses, we look at speech clarity, we look at a lot in neuro. But for today, it's just very, very basic. Okay, be fast. Do we all know this? We have Joint Commission coming to do our comprehensive stroke in 2 weeks. Every single person in-house, including cleaning staff, probably people down in the cafeteria. Everybody needs to know this. If you don't know it, please familiarize yourself with it. Balance, eye, face, arms, speech, time. Eden has the highest door to needle time in the whole Sutter system, and Perlin in the country, which is amazing. It's 30 minutes door to needle time. On the floors, we're working really hard to get our door to needle time up to rapid responses, calling code strokes, getting the patient down to CT straight away, so we can give that T and K in under 45 minutes. Okay. What's that?
Now there's no RT, just called
Yes.
stroke.
Yes, that's so that's rolled out already?
I think
Yeah.
so, yeah.
Okay, good. That's awesome. Okay, exactly. The key thing we want to do is bring the patient for a head CT to rule out bleed. And if they haven't bled here, I'm really mad, because we haven't picked up an alteration in level of consciousness. This is considered a late sign. This means that there is compression on my third cranial nerve. I have a dilated pupil. This is a late sign, very late. So we need to get these patients seeing an alteration at a level of consciousness before we get to unequal pupils, and God forbid we get to the bilateral dilated blown pupils. It's very hard to get patients back from this, right? All right. Questions on pupils? Oh, and then the last thing I'll show you on pupils, we see this a lot, pinpoint pupils. We love to give patients pinpoint pupils because we love giving opioids, right? You're going to, my patients' pupils are at 3, I give them 100 of fentanyl, now they're down to 2 and barely reactive, right? All right, moving on. Ooh, am I moving?
Something happened.
I'm frozen. We start? Okay, so Glasgow Coma Scale. Does everybody know Glasgow Coma Scale? Yes? Everyone's used it. Glasgow Coma Scale was developed in Scotland, I think in 1972. It was a way to evaluate all the drugs coming in from, so Glasgow is a big blue collar town in Scotland. They have a huge port, they build ships there, very famous port, big like the Port of Oakland. And the dock workers would get paid on Friday night and they'd go to the pub and drink all their wages away, get into fights, and then end up in the ED. Friday night, Saturday night, ED, just crawling with all these head injuries. And this was developed by Tinsdale to evaluate patients in triage. Who actually has a depressed skull fracture with a giant hematoma versus somebody who needs to just drink off their booze, right? Different scales have been tried over the years. They had a UCLA one. They had a variety of different scales, trying to develop other ones around the world. They never stuck. This one has stuck. Oh, this one has stuck. I can't go back now, right? No. This one has stuck because EMS knows it, nurses know it, paramedics know it, and neurosurgeons know it. And if I say to Jasmine, I'm coming in, code stroke, my GCS is 8, Jasmine knows that she is probably going to need to set up for an intubation.
She say room 1.
Yeah, she knows that RTs need to come down to get set up. A GCS of 8 is low, right? I can't go back on the slide, but you all know GCS. I don't need to go over it with you. GCS, the patient's either awake and alert. If they can't get person, place, time, we don't even ask them the situation. If they can't get one of those right, then they're confused, so they drop a point to 4. Then they go down to incomprehensible words. Then they, it goes down, and then they're not saying anything. We give them a 1 in the ICU a lot because they're intubated and we don't know what their speech is like. The same with motor, right? So you just fill in the boxes and then ultimately EPIC will calculate it for you. But based on that number, if my patient is like a 14, 15, I'm happy, right? I'm happy enough. The patient's sitting up, we need it for a swallow eval too, right? The very first thing we do in a swallow eval is our GCS. It's built into our swallow eval. So we need to know that our patients are awake enough to have the swallow eval done. Any questions on GCS? Has anyone ever had any trouble with it? It's very self-explanatory, and that's why GCS is used, because we say a number and you kind of instantly know how your patient's going to be, right? Okay, and we talked about the NIH with the 2-point difference. Just with the NIH, they'll score a 0 if there are no stroke symptoms. I mean, we rarely see a 0. We see it sometimes. Minor will be 1 to 4, moderate 5 to 15. Severe, though, is like 16, getting up 16 to anything over 16, they have a lot of deficit. Very severe is 21 through 42. I don't know if I've ever seen anything above 30. 42, oh my God. But these numbers become very pertinent when we have a stroke, because it's a tool. If somebody comes in and tells the neurologist, I'm bringing in a stroke and I scored him at a 38, they're like, oh God, all right. It really will impact how we're going to treat that patient, right? Are we going to bring them immediately to angio? Are we going to bring them to MRI first to see how their penumbra looks? So all these numbers mean something. Okay, so now any questions about neuro? Person, place, time, situation, awake, alert, pupils. Okay? Okay, moving on to cardiac and respiratory. I can't reiterate this enough. Another thing a lot of nurses went down on is they don't inspect before they listen. So I want you to take that gown down and look at the chest. Does my patient have an AICD? Do they have a pacemaker? Do they have an old thoracotomy site? Have they had a CABG in the past? Are they all bruised? Did they drive 100 miles an hour and wallop their chest against the steering wheel and you have a big steering wheel on the chest? Have they fractured ribs? Is their diaphragm moving up and down? How are their accessory muscles? You have to look at the chest. I also go on rapid responses a lot. How many times do I go up and the leads are all put on all janky? You know, wrong color at the wrong site, at the chest is down in their labia practically, you know, so you really do need to look at the chest. Tell the patient you're going to listen to their heart and their lungs, and you're going to feel their pulses. When you get to breath sounds, ask them to take a big deep breath in and out through an open mouth. If you do it through an open mouth, you're going to hear your breath sounds a lot clearer and you're not guessing at your breath sounds. So make sure they take a big deep breath in and out. It's just a lot easier for you to hear. And then never listen through the gowns, please, ladies. Okay, so some people studied for the prior exam and knew these off by heart and others didn't, so we're going to go through this. We have 5 auscultation points for my heart tones, right? So we'll start off. So everybody put your hands on your clavicle, hands on the clavicle, and you're going to go down to the second intercostal space. So you have a space under your clavicle, your first rib, space, second rib, space, second intercostal space. Move over to the sternal border. This is your first one, aortic. Zip across your sternum, right there on the border. This is your pulmonic. You're still in the second intercostal space. What side of my body is my heart on? The left side of my body. I've seen pacer pads. I have seen patients that I need to defibrillate with the pads on the right. My heart is on the left side of my body. I'm in my second intercostal space, and that's my pulmonic. I go down one space to my third intercostal space, and that's Erb's point. I'm still on my sternal border. I go down another space, it's my fourth intercostal space, that is called tricuspid. I go down to my fifth intercostal space, mid-clavicular, and that is mitral, okay? Why do I want to go through all these various points? Because my aortic, my S2 is going to be heard way better than my S1. I'm looking at my semilunar valves up there. Also pulmonic, same thing, looking at the semilunar valves, my S2 is going to be louder than my S1. Erb's point, they're going to be equal. S2 will be equal to S1. Tricuspid, now I'm looking at my atrioventricular valves. My S1 is going to be louder than my S2, as is my mitral. Okay, so I'm listening to my different valves in all these different spots. Aortic, pulmonic, Erb's, tricuspid, mitral. Okay? All right, moving on. For the sake of this class, can you hear it? I'm going to play you sinus rhythm. It's very, very, this is S3. I'm not going to play it for you. This is S4, also not going to play it for you, but I just want you to be aware of the different heart sounds that are out there. What I will really need you to know are your pulses. So now you've listened to your heart, you've gone through the 5 auscultation points. We're still on circulation. So now we're going to listen to my pulses. What do I want to know about pulses? The rate, the rhythm, and the force, right? The rate, fast or slow. If my patient's in a rapid AFib, my pulse is going to be rapid, okay? If my little old lady comes in, she's cachectic, she's not eating, she weighs 50 pounds, wet, I mean, she's barely there, little pale little lady, she's probably going to have a rapid thready pulse. She's probably hypovolemic, she's probably undernourished, she probably has a bad heart, that heart's going to, she's going to have a thready pulse. I get a 20-year-old in who was on meth and crashed his car, that kid should have a bounding pulse, unless he's bleeding out from that ruptured spleen and grade 4 liver lac. He also probably has a pelvic fracture and he is bleeding into his pelvis. He may have ruptured his bladder. I'm expecting in a 20-year-old a bounding, beautiful pulse, but I may have a thready, very fast pulse, right? So listen to your pulses, ladies. Cannot reiterate that enough. Okay, so say for example, I come on duty in the morning and my patient, I go down and I'm listening to the dorsalis pedis and the posterior tibial, and I go and to check my dorsalis pedis and I can't feel a pulse. What do I do next? You're going to Doppel, and you get the Doppler out, you put a load of goop on, and you're there for half an hour listening, you can still not hear it. Then what? What would you do? What would you do?
Check the other pulses, like higher up.
Good girl. First of all, you would check, okay, I don't have a dorsalis pedis, but do I have a posterior tibial? Are you going to check to make sure the foot is warm or cold? Yes, you are. If the foot is warm and you have a dorsalis pedis, you probably have fairly decent perfusion to the foot. What else am I going to check on the foot? I'm going to check my cap refill. Is my cap refill less than 3, right? Is the skin warm? How's the color? How's the sensation? Check turgor while you're down there too, but look at the skin signs. If I don't have a dorsalis pedis, I barely have a posterior tibial, I have a mottled foot that's freezing cold in comparison to the other foot. Am I worried?
Yes.
I am worried. But before I call the doctor, I'm going to check my other pulses. I'm going to check my popliteal and my femoral, because we want to see if those pulses are present. So then you're going to call the doctor with a good S-bar report. You're going to say, I came in the morning, nobody ever said anything about this pulse being absent before. I Doppeled it. I have a posterior tibial that's quite robust, and the foot is warm with a brisk cap refill, and he can feel his foot. The popliteal is there and the femoral. Now the doctor can kind of make a more educated decision on a treatment plan for that, right? But you just calling a doctor saying, yeah, I don't have a dorsalis pedis, that is terrible information. Nobody can make any sort of decision on that, right? Clear as mud? Okay, moving on.
Which ones do you want us to check out?
Okay. So for the sake of the exam, you're going to put 2 fingers on the carotid, the brachial, the radial, femoral, popliteal, dorsalis pedis, posterior tibial. And as part of your practice, this takes 2 seconds. I do it in the ICU all the time. 2 seconds to check your pulses. As you go around, in each hand, you're going to check your cap refill, the color, the temperature, the sensation, the turgor. All right? You're also going to be checking for edema. Okay? All right, moving on. Questions? Always 2 fingers.
And both, like you want to check on both arms, both legs at the same time you want? Or?
You can do it at the same time. You can do it individually. I don't really care. I mean, you're hoping that they're the same. You know, if someone's in AFib at 70, the pulse will be the same AFib at 70 everywhere, right? Yeah. Color, sensation, temperature, turgor, cap refill, pain, edema. Do we need to go through this again? We've hit it. Okay. Pitting edema, you can go from very mild, which is like 2 millimeters. It'll bounce the skin. You depress it and the skin will bounce back in less than 10 seconds. All the way over to like very deep pitting edema. This is what you're going to see in right-sided heart failure patients, that they're on a Bumix strip, they're on a Lasix strip, we're diuresing them up the wazoo, and they still have legs that look like elephants, right? So that's very deep. You'll generally see that in the right-sided heart failure patients. Okay, so for respirations, I need to know the rate, the rhythm, the depth, and the effort. Rate, rhythm, depth, effort. Okay? The rate. How fast or slow is my patient breathing? The rhythm. Is it even? Is it regular? Is it fast, slow? Are they breathing? Do they have periods of apnea? The depth. Depth is very important. If my patient is like severe blood loss, they're going to be very anxious and they're going to have shallow, rapid breathing. Effort. Effort is huge. It's huge. It's huge. I can't reiterate this enough. If your patient is using abdominal muscles, diaphragmatic breathing, you can see the accessory muscles, you know, the intercostal muscles blowing in and blowing out. They're tachypnic. They're using their shoulders. They look anxious. They look blue. That patient probably needs to be intubated, right? So know your patients. All right. And then for the sounds, I'm just going to give you expiratory wheezing or coarse crackles, right? You all know what that sounds like. And we can play those for you at the end of this PowerPoint. The auscultation of our chest, please start. I see nurses, they just go instantly here. Please start up where the apex of your lungs are. Base of the neck. You're just going to be able to listen to the great airways way better up there. Are they full of sputum? Is your patient wheezing? Is your patient in stridor? You're going to hear it up here way better. Listen, you want to make sure your lungs are expanding equally. Jasmine, that's so important for you because if we intubate patients in a, bad trauma comes in, they quickly shove in an ET tube, loves to go into the right main bronchus, right? Is that left side actually going up and down? Listen to it and make sure you see the left and the right side, lifting up and down equally. If we have any diaphragmatic damage, we often see that in big chest and abdominal trauma. One side may be going up and down unequally. Also, blunt chest trauma, tracheal deviation, look at all, there's so much to see up here. So look, I need you to verbalize before you go to any system, I'm inspecting. I'm inspecting, okay? All right, so when we go here, we are going to start at the top and work our way around and down. There are 10 points in the front of the chest, starting up at the base of the neck, going all the way down to where my rib cage ends, okay? Then we're going to do the 4 on the side. Get your mid-axilla. Number 1 is up here. You're going to go down to number 2. You're going to go to the front and to the back. You're going to get that whole lateral side of your chest. And then when we get to the back, start at just below the base of the neck, You're going to do it around the level of your C2 there, and then you're going to go all the way down, in between the scapula, 10 points, all the way down to the base of my lungs. Okay, questions about that? All right. Breath sounds. Does anybody here have difficulty with breath sounds? You know what's wet. If we're listening to crackles, generally when crackles come, you generally hear them best in the base of our lungs, right? Because it's just fluid filling up my alveoli. Coarseness, we'll hear that sometimes in the upper airways, but it can be throughout. Wheezing, generally upper airways. They can be inspiratory, expiratory. Stridor, we generally, when we have a lot of edema, laryngeal edema. With stridor, you'll hear that very high-pitched, very specific sound on inspiration and expiration. Okay? All right. These are the oxygen delivery systems that we use. We always start off with nasal cannula, and then we migrate onto a simple face mask. We can give 40 to 60% FiO2 and our flow rates 5 to 10. The face tent delivers just a little bit higher flow, but the FiO2 is only 40%, but we use this a lot for our trach patients. We can give a nice humidified oxygen through this too. When we get onto the Venturi mask, the non-rebreather and the high flow, a lot of times after this, we'll put the patient on BiPAP. We don't mess around. We like the patient to get like good ventilation. If you're on the Venturi mask and you're moving up to this, definitely the patient should probably be on BiPAP. But there's a lot of limitations to BiPAP too. A major one is we can't have patients in restraints. So if the patient's constantly pulling off the BiPAP, is that going to work? No. So yeah, just things to think about. All right, sputum. Clear sputum should be mostly watery looking. It should be clear in color. If you have a bad cold, that could become white and very viscous. Yellow, that just means your body is actively trying to fight the infection. Your white blood cells are hiding out in your respiratory system. Green, that just means that there's a lot of thick, dead white blood cells there. You see this as the day progresses. Maybe you should be on antibiotics at this stage. Pink or red, we see that a lot with trauma. So say if you have a patient with a ton of secretions, they have a very poor cough reflex, you're anti-suctioning them and you don't put a nasal trumpet in, you'll get a lot of trauma to the nasal mucosa and they can swallow that and it goes into their lungs, you know, so just be aware of that. Brown, we see that in patients, we see it in traumas, right? Kids out on dirt bikes, they bury their heads in dirt and now they're coming in with brown in their lungs. Black we see though with substance abuse. We see it in black tar heroin, a variety of the street drugs. Okay, moving on to GI. Okay, I love this picture. This picture is just showing us what is under our skin when we palpate the abdomen. So for the sake of the abdomen, what is the very first thing we're going to do? We're going to inspect. We're going to lift up the gown and inspect. We're going to look at the contour. We're going to look for stuff on it, bruising, swelling, bleeding. Do they have a colostomy bag? So we inspect. Look, listen, and feel. Inspect, then we're going to listen. We're going to start at the right lower quad and move up and around. Right lower quad, we have the ascending colon. We have our appendix. We have our small bowel. Moving up into the upper quad on the right, it's fully nearly taken up by the liver and by the distal end of the stomach and duodenum. Okay? Go across the midline. Now you have the main body of the stomach. transverse colon, descending colon, at the top of the descending. Now we're in the left lower quad. We have the descending, we have small intestine, and we have transverse there. So this is what we look at when we look at our GI. So always look, listen, and feel. Inspect. Symmetry, contour, distension. Listen for at least a minute in each part of my abdomen. And if you don't hear bowel sounds after a minute, listen a bit longer. You might have very hypoactive. We want to make sure to discern, do we have no bowel sounds or do we have some hypoactivity, right? Sometimes we have to listen up to 5 minutes. Normal is 5 to 30. Hyperactive is greater than 30. Hypoactive is less than 5. Absent is 0. So when your patients come back from the OR, they may have had really robust bowel sounds before they went down. Then we slammed them with a load of medication, and now they have hypoactive. So just be aware of that. It's something to know. You're not going to give them a cheeseburger with fries and ice cream if they have very hypoactive bowel sounds, or if they have no bowel sounds. Patients also have a lot of bowel injury and trauma. We love to see bowel sounds coming back, and sometimes it can be very slow, especially if they've repaired the bowel. Okay, palpate the abdomen. So if my patient comes in and their admitting diagnosis is severe pain in the stomach, am I going to go instantly to that left upper quad and just mash on it? No. So you're going to listen. And then you're going to feel lightly. One hand over the other. I like to start down here, and you're going to go all the way across. So on very, very light palpation, is my patient jumping out of the bed? If it's yes, then don't palpate anymore. Then you'll do deeper palpation in the other quads, right? So it's light and then deep. And we're trying to feel for masses. Okay. So, okay, light and deep. And then always, 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 for the sake of this exam, you need to ask about bowel movements. Okay, when was your last bowel movement? How did it look? Do you go to the bathroom regularly? Do you go daily? Do you have any issues? Try and glean as much information as you can about their bowel habits. Bristol-Myers stool chart, do you all know it? We document in EPIC what type of stool my patient has. Okay, genitourinary was a system too that a lot of nurses assessed. Didn't assess, and barely assessed, and maybe give me one thing on it. So let's talk about that. Which department do you think did the best on this system?
Good floor.
Labor and delivery.
Oh.
I would bladder scan the patient on Tuesday.
Really?
Yeah.
She said she forgot the last time she boarded and she can't hit her head. So I'm like, okay, I'm gonna, monitor the bladder scan thing.
Yeah, good girl.
That's so
Okay.
Because we forget it.
Yeah.
So there's a lot of aspects to this system. So let's talk about it. What most nurses forgot to do was inspect the genitalia. We have to inspect genitalia. If it's a young woman coming in, is she having her period? Is there any bleeding from her urethra? Any bleeding from her vagina? Any trauma to her labia? And, little old lady comes in. Does she have excoriation? Does she have breakdown? Does she have a prolapsed uterus that's poking out through her vagina? Like, look under the hood, ladies. If it's a guy, look at his penis, look at his scrotum. Was he in a road traffic accident? Does he have a lot of bruising down there? Especially in pelvic fractures, you really want to look at the whole genitourinary system, because if you have a large unstable pelvic fracture, it can just screw up that whole genitourinary system. You can have bleeding from the bladder, bleeding from the uterus, so definitely look at that. And with pelvic fractures as well, you really need to be very anal about checking pulses in the legs, okay? Okay, but back to genitourinary. Okay, you're going to ask the patient, are they continent or incontinent? Believe it or not, 1 in 3 American women postpartum have incontinence because they don't do pelvic floor exercises. So ask them that. If you cough, if you sneeze, are you incontinent? Okay, so then you're going to ask them about their urination habits. How often do you urinate? If you're a nurse, you may not urinate for 12 hours because you haven't time to go to the bathroom. But just ask them how often they urinate. Ask them about their urine. Do you have any burning on urination? How does your urine look? Is it clear? Does it have clots? Does it smell? Is it cloudy, sediment? How much generally do you put out? If your patient's completely with it and completely mobile, tell them you need a urine sample. Don't just pee in the bathroom. You want to see how their urine looks. Okay. And then, I don't need this as part of the test, but just so you know, for your information, we should be putting out at least 0.5 mL per kg an hour. If your patient comes up from the ED with a pure wick or a condom cath on, just don't think your job is done, right? Ask the patient, if they haven't peed on your shift, ask the ER nurse, did they pee for you down there? Haven't peed, right? They may be dry as a bone, who knows? But you do need to follow it up with a bladder scan if the patient hasn't peed. So color, odor, volume, frequency. I will ask you this, I will ask you this, and I will ask you this. Not that, this. Okay? Questions? Clear as mud? Okay. Foley catheters. We use Foleys a lot. So, first of all, we want to make sure the Foley's in the right place, that your prior nurse didn't stick this into the vagina. So just make sure you have urine coming out. You want it hanging on the bed frame, not on the side rail. You want what should be on my patient's leg to affix the Foley to? You need a securement device. You need to make sure that it's hanging below the patient, no kinks or dependent loops. And you also want to empty the Foley bag before it's 2/3 full. Never have that Foley bursting full, because you're going to have backup of urine, and now your patient's going to have a higher percentage chance of getting a UTI. Please, 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 on rounds, discuss your Foley. Do you need your Foley? If you don't need your Foley for retention or for some specific reason, like urology wants it in because this patient could have had a urethral tear or something like that, you definitely should be taking that out. Some patients, they just chronically retain. We get patients from nursing homes with chronic Foleys. A lot of our spinal cord injured patients will have chronic Foleys. Patients with pontine bleeds will never pee again. So, just be aware of that. So don't just haphazardly whip it out. Just make sure that this isn't a critical Foley, okay? All right, musculoskeletal. Some nurses completely miss this whole system, okay? So musculoskeletal, what am I looking for? I'm looking for mobility of each joint, and that the movement is deliberate and accurate and smooth and coordinated without involuntary movement. And involuntary movement, I'm talking about like Parkinsonian pill roll type things. Okay, so equal grips, get the patient a hand in each hand. This we do together. You're going to grip your patient. Have your patient grip your hands. Grip. Then you're going to lift up your arms. Okay? Keep them up. Then push down on the patient's hands. We're checking resistance. Bicep curl. Have the patient push against your hand. Make sure they can really rigorously resist and back. Okay, same here. You can do shoulder shrugs, like you're checking mobility of joints. When it comes to the legs, have them lift up a leg. You're going to press down on it. You're going to have them push down on it. Same on the other side. Press down, push down. You're going to have them bend up their knee. Push away, pull backwards, plantar dorsiflex, and then you're going to have them, if they can, if they don't have hip pain, try and get their hip out, right? Same on the other leg. Leg out, straight. Push down into it, bend the knee. Push against it, pull back, plantar dorsiflex, and then hip out. Okay? We'll go through it again. 5 is active movement. 4, they have active movement against gravity, but not nice and strong with resistance. Then 3 is they have active movement, but there's no resistance. 2 is active movement, no resistance, no gravity. And then flicker or trace movement, this is when they're just lying the hand on the bed and they can just say move the fingers a bit. And then 0 is no movement. Also, just so you know, if a patient has no movement, if they have a dense, say, right hemiparesis, I do want to see if that hand moves. So I am going to, just press down on the nail bed a little bit to see if they flex back. And I document that. No spontaneous movement, but when I give them peripheral pain, they flex. Sometimes you'll give them peripheral pain and they extend towards the pain. So that's more of a brainstem, something going on. Flexion is up in the cerebrum, extension is deeper in the brainstem, okay? Questions about this? No? Okay. All right, moving down. Skin assessment. Skin is our largest, most overlooked organ in the body. We can tell a lot about what's going on with our patient with our skin signs. Temperature, color, moisture, turgor, integrity. Okay. Color. If I'm shunting blood into my vital organs, what color do you think my skin's going to be?
Pale.
Pale. If I have a fever of 104, what color do you think I'm going to be? Flushed. So put your hand on your patient, on all their body. If my patient has no blood supply to their lower leg, what color is my patient going to be? Could be pale, could be blue, could be ashen, but probably going to be very cold, right? What temperature is your patient coming back from the OR? Frickin' freezing, right? The temperature down in the OR is kept low because of bugs. What temperature is my patient going to be coming up from trauma bay? Fricking freezing. Why? These guys cut off all their clothes. They give them a bunch of fluids. They're intubating. They're putting lines in. The patient's exposed. They're doing their primary survey. They have to look at everything. The room is cold down there. They probably don't feel it's cold because they're running around, but the temperature is cold down on trauma. They come up to the ICU. We put the bear hugger on them straight away. Because one of the main reasons patients die in trauma situations is because they're cold. And it's part of the triad of death, right? Their coagulopathy is way out of whack. So cold, everybody's cold. Always check your temperature. If you cannot get an oral temperature, what are you going to do next? You're going to get a rectal temperature. I go up on rapid responses all the time. I get a temperature. Can't get it, rectal. Get a rectal. We have rectal thermometers on the floor. Do a rectal. And then heat your patient up. Okay? So look at skin signs. The skin is going to tell you an awful lot about how your patient is perfusing. Don't overlook it. Okay, so now we'll talk about skin integrity. Where are we checking for integrity? Do we care about skin integrity?
Yeah.
Oh yeah, we do. We're going to be written up if our patient develops anything on our watch. Okay, you want to start in the hair. Is my head bony? Yeah. If I get a patient from a nursing home that's bed bound, they're probably going to have something in their hair. If the patient has an aspen collar on, I'm going to look under the aspen. If my patient has a trach, I'm going to look under the dressing. I'm going to look under that trach to see how it looks.
In the nasal cavity.
Yeah, I'm going to look in my ears, look up my nose, look in my mouth. I'm going to have them stick out their tongue. How many of our patients have thrush on their tongue? How many of our patients have been in traumas and they have loose teeth? They may not even be aware of it, you know. So look at these areas. Elbows, between the hands, for the fingers for scabies or anything else. Look in their shoulders, all their bony prominence. You're going to look in the front, knees, under the panis, under the breasts, everywhere that something may be going on. You're looking in the labia, you're looking in feet, ankles. You're going to turn your patient, and then you're going to check all their skin. You're going to take pictures of everything you see. When you get a new admit, you take pictures. If there's an alevin on, so if we from the ICU send it up to you, you're going to take that alevin off and check. Questions about skin. Dressings too. Unless there's an order to keep turban dressing on for 48 hours, keep chest tube dressing on for 24 hours. Unless there's a specific order, look underneath the dressing.
We've been told not to touch trauma dressing, not been sure if that's still in effect. On our floor, when patients come.
Unless there's a specific order, and when trauma come up and round in the morning, ask them. Yeah. In the ICU, we have we always ask about dressings. They will say when the patient's coming out of the OR, keep this on for 48 hours. But say, for example, the patient has a peg tube. We put those little 4x4 with the slits underneath that. Take that down, look under that. That's a common site for skin breakdown. Okay, and just regarding dressings, like trauma dressings, whatever, ask Azimi, ask Phillips, do you want me to have a look under this? All right.
I would say probably just the doctors are particularly trauma docs. That's probably why they say don't touch it.
Okay, Braden scale. Do we all know the Braden scale? Okay. These are the areas in the body that are more apt to develop breakdown. Supine, lateral, prone. Sitting out of bed in a chair, these are the areas. Even if your patient's sitting out of bed in a chair, you have to have that air cushion underneath them and change their position. All right, pain. Pain is another thing that I know you all ask your patients about pain. I know you do, but for the sake of this little exam, a lot of people forgot to ask their patients about pain. So my little tip for that is when you're doing your neuro and you're saying person, place, time, situation, then boom, ask them about pain right then and there. Because you do actually want to ask about pain at the beginning of your exam. Because if, say they have a flail chest, say if they have every rib is fractured on one side, you don't want to be lying them on that side to check their skin. You don't want, it just makes the exam a bit better for your patient, right? And then you ask them about pain before you do your exam, but say to the patient, if you have any pain at any stage during this exam, let me know. And then promise them that if they have pain before, just say to them, I will give you some pain medication the minute this exam is done, because this exam will only take about 5 to 7 minutes, okay? All right, so use an appropriate pain scale. I'm not too sure what you guys use on your floors. I will say in the ICU, I think we have 5 pain scales. So if Roselle was doing CPOT, the critical care one, and I decide to come in and do the face one, I should really continue with the CPOT one, so we're not bouncing around with different pain scales. We're not going to do kids unless any of you really want to go over kid. Okay. But I will go over pain in the elderly because you know little old dears that come in, they're on, 2 shopping bags worth of medication, right? They're on a ton of medication. They're on 3 times more medication than the general population. They're also kind of poor in adhering to the directions of their use, probably because they forgot that they took that Norvasc this morning. So, ooh, let me pop 2 more just in case. They also, their physiology changes. Their liver metabolism and renal excretion, do you think it goes up or down as they age? It goes down. Their liver function tests, their renal, their BUN and creatinine goes up with age. So older people are at a much higher risk of adverse reactions, right? Go low, go slow. So we love to give our little old dears morphine, fentanyl, Dilaudid. We should think of other adjunct medication that we should give to them because we love in our ICU to put them into delirium. We're very good at doing that in our ICU. We also over-sedate and probably over-opioid our trauma patients. So we really are trying now to, all right, ladies, now we're moving on to a complete head to toe. And this is I'm just going to do what you need to know for the sake of this assessment, okay? All right, here's my patient, Miss Rizal. Thank you, Rizal. All right, so I'm going to walk into the patient's room. Knock, knock. Good morning, Rizal. How are you?
I'm good.
I'm Sharon Jelly. I'm Sharon. I'm going to be your nurse today. How are you?
Okay.
I'm going to do a head-to-toe assessment on you this morning. We do this on all our patients. I'll be doing this throughout the day, but this is the first time I'm meeting you. So how are you? How was your night? Did you sleep okay?
Mm-hmm. Yeah.
Yeah? How many hours sleep do you think you got?
Like 2 or 3.
Okay. And are you in any pain right now?
My shoulder kind of hurts.
Okay. And apart from that, is there anything else concerning you?
No, that's it.
Okay, fine. And do you know what brought you into the hospital?
Well, I went out and had a couple drinks,
Hmm.
and then I woke up here.
Oh, okay. Well, good. So we're going to go. I'm going to just see how you are, and I know your shoulder is sore, but I'm actually going to look at every system in your body, okay? All right. If anything is painful or irritating for you while I do this whole assessment, please just let me know. And I know you have pain in your shoulder, but I'm going to actually do your assessment first and then deal with the shoulder pain when I'm done, okay? We have a few tricks up our sleeve for that, okay? So, and some of the questions I'm going to say to you are super silly and you'll wonder why I'm saying it to you, but anyway, bear with me. Okay, I'm just going to look at your armband. So can you tell me what your full name is?
Mickey Mouse.
All right, Mickey Mouse. And then what's your birthday?
It is February 29th, 1992.
Okay, and do you know that your actual name is Rizal Lum?
Oh, yeah, that's correct.
Okay, and your actual birth date is July 4th, 1991?
Oh,
Yeah.
yeah.
Okay,
You're
all
right.
right. So what's your name?
Rizal Lum.
And your birthday?
July 4th, 1992.
Okay, so that's person. Okay, Rizal, do you know where you are right now?
I am in the hospital.
Oh, very good. Do you happen to know which hospital you're in?
Eden.
Oh, well done. Okay, and that's in Castro Valley, right?
Correct.
Okay, so person, place. Rizal, do you happen to know what month of the year it is?
It is June.
And the year?
24.
Okay, very good. So June 2024. So person, place, time, and now situation. And what brought you into the hospital?
I had a couple drinks.
Yeah.
And walk up here.
Okay, very good. So now I'm going to shine a bright light into your eye. There it is, and her pupils are constricting nicely. I see some consensual response over there, and I'm going to come in here and do the same. Her eyes, her pupils are both looking forward. I don't see any trauma. She looks like she's tracking me. Done with pupils. But for the sake of the exam, I just need you to shine a light into her eyes. Okay, just for the exam. Okay. Rizal, are you having any pain right now? Just your shoulder. So 0 is no pain, 10 is the worst pain you ever had. Where would you say your shoulder pain is?
6.
Okay, all right. Who are you? All right. So now I'm going to move on to your chest, and I'm going to just inspect it first. So I'm taking down your gown. I'm looking for any trauma to her chest. Do you have any pain in the chest area right now? Okay, very good. I don't see any bruising. I don't see any swelling. She doesn't have any paraphernalia on. She's on telly, but the telly leads are on okay. So I'm going to just listen to your chest now, listen to your heart sound. So I'm just going to go down into your second intercostal space. So what is this? Aortic. Second intercostal space. I move across the sternum to the other sternal border. What's this called? Pulmonic. Aortic, pulmonic, second intercostal space. I go down to the third intercostal space, Erb's point. You're on the sternal border still. Fourth intercostal space, tricuspid. Fifth intercostal, midclavicular, mitral. Aortic, pulmonic, Erb's, tricuspid, mitral. Okay? All right, and then I'm going to play you a very difficult rhythm. Not really. I'm joking. Okay, next I'm on circulation still. I'm going to listen, pulses, pulses. When I'm on each hand, I'm going to check cap refill, color, temperature, sensation. How does the sensation in your hand feel? And what else? Color, temperature, turgor. So we're going to lift up the skin. Looks good, goes back to normal. What's next? Cap refill. Color, temperature. Okay, very good. Okay, in both hands. I'm also going to check her carotids. Okay, very good. Okay, radial, sensory, color, skin, all the above. Then I move down to her feet. I'm going to do dorsalis pedis and posterior tibial. I'm also going to check her cap refill. I'm going to check for turgor sensation, okay, in both her feet. Okay, circulation, do you think circulation is done now? Okay, I'm still inspecting the chest. I'm inspecting to make sure her rate, her depth. Does she have any difficulty? Is she using accessory muscles of respiration? Does she have any cyanosis? How's her O2 sat? I'm looking at all of that. See if she has equal rise and fall on both sides of her chest. Make sure that her diaphragm is lifting up and down appropriately. She's not using her accessory muscles, her intercostal, her shoulders to breathe, her diaphragm. I'm looking at all of that, okay? And she's breathing normally. Then I'm going to listen to how many points in the front of the chest? 10. So I'm going to start at the base of the neck. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now I'm going to go over to the side, mid-axilla. I'm going to go 1, 2, 3, 4. Right? Then I'm going to go to the back. 10 on the back, starting right at the base of the neck, between the scapula. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? Then what am I going to do? Play you a very difficult lung sound now. It'll be easy. Okay. Now we're going to move on to the abdomen. What's the first thing I'm going to do? inspect, lift up the gown. Look, listen, feel. Always look, listen, feel. So I'm going to look first. I'm looking at the contour. I'm looking to make sure she has no swelling. I'm looking to make sure she's no bruising, any colostomies, ileostomies, whatever she has. You know, what's the output from it? Does she have a wound vac? Is it working properly? Whatever you've got going on in the abdomen, look. Then I'm going to listen. How long am I going to listen? More than 1 minute. So starting down in my right lower quad, listen, 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 listen. Okay? All the way around. If I don't hear any gurgling in that minute in each quad, listen longer. Listen up to 5. You want to listen to make sure you hear something. Okay. Once I've listened, what am I going to do now? I'm going to palpate. So just let me know, Rizal, if this hurts. I'm going to do light palpation first. And was that okay? And I'm going to go deep. Is that okay? Good. And when did you have your last bowel movement?
This morning.
Oh, good. And how did it look? How was it for you?
It was okay.
Okay, good. Any diarrhea, any constipation? How was your diet normally?
Okay.
Okay. And you have bowel movement every day?
Yes.
Okay. And then, do you drink enough? Like, not alcohol? Water?
Yeah, water.
Yeah. Okay, good. All right, fine. And no other GI issues? No reflux? Nothing? You're not taking antacids or anything like that? Okay, very good. And then if my patient was over 60, I'd ask them if they had had a colonoscopy anytime recently. But for the exam, you don't need that. But I'm just saying in general, you know, for a good exam. Okay, so now we've done the abdomen. What are we doing next? GU. Okay, what's the first thing I'm going to do? Inspect. Going to look for any breakdown, excoriation, any bleeding. If it's a man's scrotum, look at the penis. If you get them up from the ICU, or you know, make sure you check to make sure there's no breakdown under the condom cap, things like that. Okay, so then we're going to ask Rizal. So Rizal, how is it for you peeing? Do you pee normally, do you think? Have you ever had a UTI?
No.
No burning when you pee? Your urine when you pee, how's the color?
Okay.
Is it clear?
Yellow.
Clear yellow? Okay, no sediment or blood or anything in it? And you think you pee normal volumes? And generally, how often do you pee?
Every few hours.
Okay, very good. So next time you pee, I'm going to leave a receptacle in your bathroom. Will you pee into that just so I can examine your urine, make sure everything looks okay? If Rizal came up from the ED with a Purewick in, if she does, you know, make sure you ask your ED nurse who brings her up or who's been caring for her if she peed down in the ED. If she didn't pee down there, and now it's like at the 4th hour, make sure you bladder scan her. Okay. Okay. If Rizal had a Foley, we would make sure we'd inspect it. We always do Foley care when we get the patients up from the ED. Make sure you start from the insertion site and work out.
I don't have to change it every time they come in or go with ER first. That's
Change
our
it?
policy. Policies always change out for the patient or the ER.
From ER?
Yeah, if they don't go to the ER, we have to do it on
Oh, you mean if they come from
Yeah,
a nursing home? Oh, okay.
Yeah.
Oh, I thought you were changing it when they come up from ED.
No.
Oh, yeah. Yeah.
No.
Okay.
Always change it when come from SNF.
Okay, that's fair enough, but that's probably a good policy. I hope you're getting a urinalysis if you do that.
Oh, yeah, as a baseline.
Yes, good. All right, so if you get your patient up with a Foley, do Foley care, make sure they have stat lock is on, make sure that it's lower than the level of the bladder, attached to the bed frame, not to the side rail, and make sure you look at the color, the volume, any sediment, any odor, and how often they're
voiding. It should be every hour. We do it every hour. And then the other thing is with urine, if you start to see stuff, just check with the doctors before you do a urinalysis or a culture, and always discuss on rounds if you actually need it, right? We like to get bolies out as quickly as possible. Okay, moving on now to musculoskeletal. What are we checking in musculoskeletal? We're checking to see how they move, how their joints work. Do they have any extra movements that shouldn't be there, like patients with Parkinson's, pill rolling, all that. So, Roselle, let's lift up your arms, nice and strong, hold them up there. I'm going to press, resist me, resist. Okay, good, resist. Squeeze me, tight, 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 tight. Okay, good girl, let go. Flex up, push me away, pull towards me. Very good. Shrug your shoulders. Very good. No pain when you do that? Okay, good. Lift your left leg up. I'm going to push down, resist strongly. The other way, push down, bend up your knee. Push me away, push the other way. Plantar flex, dorsiflex. Very good. Other leg straight up. I'm going to push down, don't let me, bend your knee, and then push, pull, plantar, dorsey. Can you move your hip out if you don't have hip pain? Right, very good. Okay, what's next?
Pain and psychosocial.
Skin, we'll do skin next. So skin, let's do skin everywhere. So is my cranium bony? Is it a bony prominence? Yes, it is. Check through the scalp. Make sure there's no breakdown in the scalp. This is particularly pertinent if your patient's coming from a nursing home, right? Because they can be lying in bed with a broken area in their scalp for a long time. So check that. Check in their ears. Check up their nose, check in their mouth, stick out your tongue. Okay, check for any loose teeth. Anything feel loose? Okay, very good. You're going to check all. Take down their gown, look under their gown, look at their shoulder, look at their under bony prominences, all their bony prominence. Check between the fingers, any scabies. Check, roll them over. Any wounds, check underneath. They may have been stapled up the yin-yang down in ER. Check underneath, make sure there's not a massive hematoma under there. If they have chest tubes, check those, check to make sure connections are good, check underneath, make sure it's sutured in. I don't know if you guys look at chest tubes. Do you look at chest tube dressings? Very good. If you get a patient up from ICU, check under all the elements. We'll often send patients up to you that might have 10 elements.
We take all the pictures anyway.
Good, very good. And that's it. If you get a new transfer up, take pictures. If you get a new admit, take pictures. We take pictures Monday, Wednesday, and Friday in the ICU. We're always taking pictures. Make sure the patient has adequate, I don't know what kind of beds you have, but do they have the waffle mattress? When you get them out to the chair, do they have the waffle underneath?
We're getting rid of the waffles.
No more waffles.
Oh, for you? Yeah, we don't use them at all. And then, use wedges, use all the tools available. And then after the whole thing, we asked her pain at the very top. So then, Roselle, did you have any further pain?
No, just here.
Okay, fine. So we'll look into that. And then family, will family come in and visit you? Yes, okay. Anything else you need from me? Here's your call light. Call me if you need me. I'll be back in an hour. Okay.
Thank you.
Okay, that's it. Do you want me to do it again? No? Feel fairly confident? Okay. All right. All right, kids, practice time. Practice among yourselves unless anybody feels like they know it really well and want to try out now. Huh? Do you want a few minutes practice or are you good? Yeah.
I think, yeah.
What?
I think so.
You want to practice?
Yeah.
Okay. So there's 3 of you, so why don't the 3 of you do together?
Well, we have to wait.